Hello, everybody, and welcome to the second last talk of the evening. One moment. One moment. Okay, can we share again, Mike? Hi, everybody. We're just trying to set up Mike on his with his PowerPoint. 1 second now. There we go. Okay, I'd like to welcome Professor Michael Watts, Associate Professor Clinical Medicine in University Limerick. He's the co-chair of VT Ireland and Associate Clinical Director in UHL in unscheduled care. His research interests are ageing and respiratory function, bronchoscopy, sedation, inflammation, coagulation, and the role of the direct oral anticoagulants. He's into health service reform and organisation. Absolute pleasure to have you here, Professor Watts, and we're really looking forward to your presentation on post-thrombotic syndrome and complications.
Thanks very much, Anne-Marie, and thank you personally for organising this fantastic meeting and a fantastic set of speakers. I mean, Thrombosis Ireland would be nothing without you and your organisational abilities. Patient advocate, and also as an advocate for reform in terms of how we look after thrombosis, your presence is certainly extremely important. And thank you for the invitation, and also thank you to Brian for helping us get set up. So I hope to be clear. I know the mic we've had a few issues with, so I'll speak loudly and clearly. And if there are any issues, Anne-Marie, feel free to interrupt me. So, to begin, post-thrombotic syndrome and its complications. So, well, here we go, I'm ready. Changing slides. Okay, so the outline of what I want to talk about today is just very briefly about VT, and particularly DVT and blood clots. And I'm sure that many speakers today and yesterday have given you an outline of how common these things are, and particularly to talk about the post-thrombotic syndrome. Particularly what we call the post-phlebitic syndrome. In other words, what can happen as a complication of DVT in the lower limbs, and what it's like to live with VT and the issues that can crop up quite frequently. And then I hope to have a fairly lively Q&A afterwards, following the presentation about this syndrome. As you know, DVT, blood clots in the leg, is extremely common. I'm a physician, I work in a hospital, a big hospital, and I would expect nearly on every take that we would have a clot coming and presenting acutely. Now, in Limerick, what we do is we have a system whereby patients presenting with blood clots actually are diverted into a nurse-led, nurse-driven pathway, which avoids trolleys, which avoids long waits, which avoids the heartache of coming into an acute hospital, which probably now more than ever with COVID around is more important than ever. And what we see in our nurse-run DVT clinic is up to 20 presentations a week. It's a really, really common presentation. One of the really very interesting things about something that's very common is actually at an organisational level how poorly things are organised. We've got heart attack doctors and we've got stroke doctors, but we don't have dedicated blood clot doctors, despite the fact that these clots are the third biggest cardiovascular killers in Europe, 150,000 deaths a year. So it's ironic that you would think that something so important and so common does not have a clear leader in Ireland. In most European countries, there is a clear, defined specialist who deal with these problems. In Ireland, unfortunately, we don't have that. And again, one of the things that Anne-Marie is very important in helping us organise is developing a clinical program or a defined process nationally that we can push forward and agree to, which Anne-Marie has been very helpful with us in promoting it. COVID has put a pause on, but we're reinvigorating those discussions now. So, after a clot in the legs,
Professor Watts, somebody just suggested that maybe if you remove the stethoscope, it might improve the sound. Give that a go and project. Thank you.
Okay, is that better? I'm sorry about that. post-thrombotic syndrome or the post-phlebitic syndrome is a consequence of a clot in the leg, and what that clot does is increases the pressure in the venous system. Now, the pressure in the venous system is usually low. Arterial system, the pressure is high. So arteries give blood to the tissues, veins drain the blood away back to the heart. And the venous system usually runs a low pressure system. The venous system in the legs, though, is very much affected by gravity. So when you stand up, even though the pressure is low, blood tends to sink to your ankles. And what stops the flow of blood going to your ankles are these delicate little valves that exist inside the venous system. And when those delicate little valves fail, blood goes backwards. So instead of going from your ankles to your heart, it ends up going from your heart to your ankles. And that causes swelling and that causes pain, the most common symptom of the post-phlebitic syndrome. And of course, what damages those valves in the first place is commonly deep vein thrombosis, or DVT. That's just a picture of the anatomy of the veins, starting at the top from the big vein in the body we call the inferior vena cava. So that's effectively the vein that drains the total body, from your legs to your gut, to your liver, to your kidneys, all that venous blood back to your heart. And of course, the journey of that blood starts distally in the lower limbs. And the further down you go in those lower limb veins, the higher the pressure. And the little valves, I think you can see my pointer here, the little valves that exist above the knee, below the knee, and around this area here called the saphenofemoral junction. And that's where there are also little perforator valves that connect the superficial venous system. So these are the superficial veins that sometimes present as varicose veins, the veins that you can see on your hands. They're superficial veins. The veins you can see bulging in your legs, they're superficial veins as well. And they communicate with these veins, the deep veins, through these little perforators. So these are the deep veins. You can't see these veins, but this is where the clots occur. And these clots are a problem. And the reason they're a problem is because if they let grow long enough, not only do they cause increased pressure, but the clots can break off and go up these veins here, up the IVC, and lodge in your lungs, and we call that a pulmonary embolism, okay? So the complication of a DVT, of course, is a pulmonary embolism, and that can be very, very serious. But the other complication that I'm talking about today is what the clot does to the veins and the damage the clot causes to the veins, and in particular, these little delicate valves that allow only one-way flow from the foot to the heart. So that's an acute DVT. This is a big, red, swollen, angry-looking leg. And you can see that as well as this leg being pink, it's much more swollen than the good leg here. So this is the left leg, and when we're diagnosing a DVT, we have a score called a Wells score that is a clinical prediction tool to predict the likelihood of a DVT, and it includes things like the measurement of the calf, comparing how swollen this calf is to that calf, and we do it from a particular distance from the knee bone here, and ultimately what we would do in this scenario is get a scan to confirm the clot in the deep veins. And the scan that we would normally get is a Doppler, and I'm sure that's been discussed already. A Doppler is an ultrasound test. It's not a dangerous test. It's using the same technology that pregnant ladies have on their babies, and it can show a lack of flow and a lack of compressibility of the deep veins, which confirms the presence of a deep vein thrombosis. So you can imagine that this deep vein thrombosis is, as well as causing the pain and swelling, is going to damage the little delicate valves inside the vein. So the clots, what they do is they block flow. So when the venous flow from the foot back to the heart is blocked, pressure builds up behind it. It's a bit like a blocked river. If a beaver comes along and builds a dam in the river, what happens is the flow is stopped and the pressure builds up behind the dam. And that is what causes the swelling and the pain of a DVT. The types of clots that are really the bad ones in terms of causing pain and swelling and also damage to the veins are those clots that cause complete occlusion. Some clots only cause partial occlusion. And obviously, if there's a partial occlusion, you can still continue to get flow. But if the occlusion is complete, you tend to get much more pain and much more swelling, and a rapid increase in that venous pressure. What should normally be a low pressure then becomes a high pressure system. And then what happens with these delicate little valves is they get damaged and you get backwards flow. In other words, flow going in the wrong direction. Instead of flow coming up from the foot back to the heart, you get flow going back in the opposite direction. And then flow not only going back into the opposite direction down towards your ankles, you can get then flow through the little perforated veins into the superficial veins. So you can get swelling and distension of the superficial veins as well. And you can often see them, big bulging superficial veins because of the acute pressure that's built up. So these are these little valves that I've been referring to, these delicate little valves, and you can see how ideally this is your foot down here, this is your heart and your top of your leg here, that if these valves get damaged, instead of only allowing flow upwards, you get a bit of backflow and this blood leaks backwards, and that's what causes the pain and that's what causes the swelling. And you can see how why this problem will be worse in your foot, if you like, than in your thigh. Equally, the higher the clot, the worse the backflow. So the post-thrombotic syndrome is much more common in high DVT. So DVTs up and around the groin area or the femoral area. Now they can still occur with DVTs below the knee, but they tend to be far worse and more significant in DVTs above the knee. And that's of course because the veins are bigger and there's much greater distance for the backflow and the pressure to build up. So that increase in pressure in the venous system actually sets up an inflammatory response. So the immune system reacts to this increased pressure a bit like it does to an infection or any form of damage. It causes inflammatory cells to come along. The inflammatory cells, their job is to try and repair the problem, but of course it can't repair the underlying high pressure that's driving it. So that inflammation, unfortunately, causes more damage. It can further damage the valves, and it can further damage the subcutaneous tissue, the tissue between the valves and the skin, and can also damage the overlying skin. And in fact, many of you that have this problem will end up with a discoloration of the skin, and that discoloration of the skin we call hemosiderin. It doesn't matter what word it is, but it's a sort of browny. It looks like rust nearly, a browny tinging stuff. It's red cells that have the pigment inside the cells leaking into the skin and effectively staining the skin. And as the blood bursts through these little delicate capillaries. So a combination of pain, swelling, this sort of hemosiderin staining of the skin, all worse, most particularly bad around the ankles, which is the highest pressure, and then edema, which is fluid being pushed out, causing swelling. And over a period of time, this can lead to scarring. And so the skin gets so damaged that the fat can be eroded away, the skin can get broken down, and of course, the real feared endpoint of this problem is the development of leg ulcers, what we call venous ulcers. This is really the worst thing that, the thing that we try and avoid altogether, because these venous ulcers are very, very difficult to treat. They're very painful, and then they can get infected as well. And as they get infected, they can actually cause further damage and potentiate further ulceration. So this is what it looks like to start with. This is this browny, dirty, sort of pigmenty looking ulceration. It tends to occur around the ankle area. It sort of looks, it's sort of a browny color, and you'll see it in people who've just got varicose veins as well without DVT. But you can see this discoloration here, that they're beginning to skin. You see, if you look right in the middle of this picture, the skin is starting to break down. So that's the beginnings of the dreaded venous ulcer. This is another example of someone with the post-thrombotic syndrome who's developed an asymmetrically swollen right leg. You can see the right leg is much more swollen than the left. Look at the hair difference here. So you've got a normal sort of hairy leg here. See how the hair is all gone here because the tissue has become all damaged. You've got this sort of browny, tingy, hemosiderin color that I referred to in the previous slide and the swelling that goes with it. So this leg is often quite painful. And again, the skin, if you look in this area here, quite damaged. The subcutaneous tissue is quite damaged. And again, you've got the risk of potential ulceration. It hasn't occurred here yet, but actually looking at this skin, there's some scarring here. So you wonder whether in the past this patient may have had a venous ulcer that's partially, or that's healed, but has left a lot of skin damage, a lot of scarring behind it. And this is the dreaded ulcer. So this is, again, you notice it's in the same position here as the ankle where the highest pressure is. So we got the venous ulcer, so the skin is completely broken down here. You've got the subcutaneous tissues being eroded into. You can see underlying muscle there and fat, and around it there's a lot of scarring around the edge of the ulcer, and evidence here. You can see this brown tingy here stuff. Again, this is the hemosiderin staining that I was referring to. So this is what we don't like to see. This is when things have really gotten to a point now where you're in really serious trouble. These ulcers are very, very painful and present huge dilemmas for us as clinicians as to what to do with them. But I will talk to you a little bit later about what we do with them. So the signs and symptoms of the post-thrombotic syndrome, so intermittent or persistent swelling, commonly after a deep vein thrombosis. When your DVT is diagnosed, the pain often doesn't go away. So one of the really common questions that I get in the blood clot clinic is, why hasn't my pain gone away? I've got my DVT diagnosed, I'm on my blood thinners, but it's 2 or 3 weeks later and the pain is still there. What that pain is the pain of venous hypertension. And it's because the clot does take a while to disappear. The blood thinners don't dissolve the clots. What the blood thinners prevent is further clot formation, and allows time for your own body to absorb the clot. And if you've got a big occlusive DVT, that can take time, sometimes up to 6 to 8 weeks. So when you get these signs and symptoms, the first thing to do is to try and relieve the pressure. And it's the pressure that's driving the pain and the pressure that ultimately can cause the post-thrombotic syndrome. So what I tell my patients is to do in the acute stages is to try and elevate their limb as much as possible. Take away the effect of gravity. At night time, bang a pillow under the foot end of the bed, not under your feet, under the mattress, and that'll just raise your mattress a few degrees, and that keeping your legs slightly above the level of your heart while you're sleeping will reduce that venous pressure, reduce the pain, and ultimately reduce the potential damage that increased venous pressure can give you. Often what people say is the pain associated with the DVT is worse at the end of the day, and that's because you've been on your feet all day. And as you've been on your feet all day, that venous pressure has been building and building and building, causing the pain, causing the swelling. And it's ultimately that process, if let go on for a long period of time, cause the discoloration of the skin in the slide that I showed you before, and ultimately then breaking down of the skin, scarring of the skin, and ulcers. And then ultimately, even after the ulcers have healed, atrophy of the skin. So the skin initially will become infected and ulcerated, and then become very, very thin and very weak, and then potentially at risk of recurrent ulceration. So this is someone here, again, you can see, who's had long-standing venous disease. And often what happens is the swelling can actually disappear because of scarring. So the scarring can sort of almost provide sort of like a bandage around the legs, but it doesn't take away the problems. You can see how blue these feet look because of the high venous pressure, and again the dreaded venous ulcer. And above it, the clue there is the staining, this hemosiderin staining. So this is what happens. This is the ramification of long-standing venous hypertension, which is why it's really important to deal with the DVTs at the beginning. You don't want to end up in this situation. So the risk factors for developing this are the size of the clot. The bigger the clot and the higher up the clot, the higher the risk of this happening. Again, as I said previously, a complete blockage is worse than a partial blockage, and I guess that's pretty obvious. If there's still a bit of flow, the chances are this is less likely to happen. The other group is people that get recurrent DVTs, so clots over and over again. The more damage to the valves, the higher the pressure, the more likely that this syndrome is going to occur. Now, the really interesting thing is that some patients have this and they say, well, doctor, I've never had a clot. I've never had a blood clot diagnosed. And my answer to that is that you probably have and you're just not known about it. And this is one of the problems with DVTs, is that sometimes people don't always get symptoms of it. Sometimes venous hypertension isn't due to DVTs and it's associated, I suppose the next most common thing would be obesity and then pregnancy. So recurrent, people that have had a lot of pregnancies and people with a very high BMI can also cause venous hypertension, which can also cause the syndrome. But of course, DVT in my book. Exclude DVT. Always get that doctor done, get assessed, and make sure the clot isn't there. Because the best treatment for DVT is anticoagulation, and recurrent DVTs is anticoagulation. People often ask me, with varicose veins, are the varicose veins caused by venous hypertension? Yes, they can be, but varicose veins can occur without venous hypertension. Does removal of the varicose veins deal with this problem? No. Most of the time, varicose veins are operated on for cosmetic reasons, and also symptoms and pain, and that's okay and understandable. But does having varicose veins removed prevent you from developing the post-thrombotic syndrome? No, it does not. In fact, it can make it worse sometimes. So always make sure when you're getting your veins done, you're getting it for the right reason. Weight reduction is a very important part of the treatment of venous hypertension, and it does work. And of course, aging is a risk factor. Unfortunately, we cannot do much about that. In fact, our goal is to get older every day. So aging is a significant risk factor. Another risk factor for developing the post-thrombotic syndrome is this thing called the residual clot. Now, what that means is the clot appearance hasn't disappeared. So another common question I get from patients, excuse me, after diagnosed a clot is, has the clot gone away? Has it disappeared? Have the blood thinners dissolved the clot? And in fact, what we see in a lot of patients is the answer to that is essentially no. In other words, the appearance of the clot is still there. It may not be the fresh clot that was previously there, but that there is an organized clot. And that anticoagulation sometimes does not get rid of that. It doesn't matter how long you take the anticoagulation for. And we often see it in clots below the knee. And so the key thing is not to be worried by those clots, because they're not really clots and they're a very little risk to you. But what we do know about patients that don't recanalize, as the word is, so in other words, don't reopen up completely and have evidence of this so-called residual clot, is that they are at increased risk of developing venous hypertension and the post-thrombotic or the post-thrombotic syndrome. Okay, so they are an important risk factor. So it is important to know about this. It is important to be aware of it, because it does increase your risk of the post-thrombotic syndrome, and it does then heighten the importance of trying to avoid it. And I'm going to talk about in a minute how to potentially avoid this syndrome. Right now, in fact. So obviously the best way to prevent the post-thrombotic syndrome is don't get a clot in the first place. Be active, keep your weight down, don't smoke, exercise. So your veins are supported by the muscles in your calf. So exercising your calf muscles is really important in terms of preventing DVTs, but also in preventing the post-thrombotic syndrome. So exercise is one of the key things. Obviously anticoagulation if you've got a DVT, and if you've got recurrent DVTs, potentially long-term anticoagulation. Low-molecular weight heparin, which is the injections, equally we use in the acute phase on occasion. There are some surgical treatments, but they are fairly controversial. Mechanically removing the clots for DVT, again, I've had a phone call literally just before this teleconference about whether someone should have their clot manually removed as opposed to anticoagulation. Rarely do we need to do that with good anticoagulation, but on occasion it is done. What about stockings? So again, a really common question I get asked all the time. So in terms of DVT prevention, stockings are not recommended. In terms of swelling after DVT, they don't work either. Unfortunately, they don't prevent the post-phlebitic syndrome. They are useful, particular types of stockings, in venous ulcers, okay? This so-called 4-layered compression bandaging, done by specialist nurses. And what we know in people with venous hypertension and venous ulcers, the 4-layered bandaging works. It's how you treat the venous ulcers, along with all the other measures. But in terms of deep vein thrombosis, if you have a DVT, the evidence for wearing stockings is sometimes those stockings can cause more harm than good. So the guidelines now from the European societies, from the American societies, from the International Society of Thrombosis and Hemostasis is that we do not recommend the use of stockings in people with diagnosed DVTs. It doesn't prevent recurrence, and it can often cause more harm than good. Now, in people with long-term swelling, however, people with the post-phlebitic syndrome, what I say to them, the stockings do provide support, and they sometimes can provide relief. They may not prevent DVT, but they may give some symptomatic relief. And as long as you can get them on and get them off, and they're not causing breakdown of your skin or any pain, no problem. But again, to be very clear, we do not any longer recommend the use of stockings after the diagnosis of a DVT for the purpose of the DVT alone. So stockings, studies have been done, published a couple of years ago, no longer recommended. I suppose the other thing with the post-phlebitic syndrome is to be aware that there are many other mimics that can cause leg swelling. Obviously, see your doctor. There are things with the knee that can cause leg swelling that can mimic venous hypertension. You can get blockage of the lymphatics that can mimic it. These things can all mimic DVTs. Obviously, trauma can do it as well. So it is important to go to your doctor and get it diagnosed properly and make sure that we're dealing with venous hypertension. And of course, the best way to do that is get an assessment from a doctor. You get a Wells score done, maybe a D-dimer according to what the Wells score is, and then a Doppler test to say, is there a clot there, isn't there a clot there? The treatment of the post-phlebitic syndrome or the post-thrombotic syndrome is exercise, exercise, and exercise. It's all about calf muscle strength and increasing that calf muscle strength. Swimming is a great form of exercise for this. I mean, again, the problem with the post-phlebitic syndrome is gravity and venous hypertension. And the great thing about swimming is it's effectively a 0G form of exercise. So it's a really good exercise to do. It's good for your heart, it's good for your veins, it's good to strengthen those muscles in the calf that support your veins. It helps with weight reduction, it helps with quality of life, it makes you feel better. And so it's a really good thing to do. Now, people ask, well, I've got leg ulcers, can I swim with leg ulcers? The answer to that is yes. If they're bandaged up appropriately, yes. As long as they're not infected, swimming is fantastic. A pillow under the foot of the mattress, as I said, again, what that does is just takes that little bit of gravity off, particularly when you're lying down. The principle is get your foot above your heart. And if you can do that, you'll get venous drainage occurring at night when you're asleep, and you'll wake up in the morning and you feel much, much better. Compression stockings, yes, if it helps. It's not mandatory. It doesn't reduce the risk of DVT, as I said previously. The only reason we provide 4-layered compression stockings in this syndrome is if you've got a venous ulcer. Skin softeners are useful. So I kept some of this stuff here. So particularly, I don't know, can you see this stuff? This is Hydromel. I'm not advertising. I think it's non-generic. What it is a paraffin-based skin softener. Works really, really well in people with swollen that venous hemosiderin discoloration that you get around the ankles, and it really does help. We sometimes use Betnavate, topical steroids. One of the problems with the topical steroids with this is it can cause further thinning of the skin, which again isn't great in someone that's already got potential skin damage from venous hypertension and the post-phlebitic syndrome. But again, it is occasionally used when you get a lot of skin inflammation, but for short periods of time. This stuff you can use all the time. It's harmless, has no steroid in it, and it's cheap. You can use it in the bath. Great stuff. The surgical interventions for the post-thrombotic syndrome. So a bit like blood clots in the legs, where surgical intervention is controversial, as I alluded to before. Surgical intervention for venous hypertension is also quite controversial. There's no really good studies looking at the various things that can be done, including stenting, bypass surgery, valve reconstruction. So what I would say to you is that there are vascular surgeons that do this. They organise very particular types of tests, venous ultrasound tests, to look for incompetence. And I would occasionally refer the odd patient to my vascular surgical colleague under very specific circumstances for this. But on the whole, the evidence for the surgery, unfortunately, is not great. There are relatively small numbers of patients that are suitable for the surgery compared to the number of patients we see. So the prognosis, what happens? If managed appropriately, half the patients who develop this syndrome remain stable or improve. So that's good, but of course what that means is half don't. So, you know, it is a really important syndrome to recognise. It does have a huge impact on quality of life. It can cause significant pain, can cause significant burden to patients and to carers, and significant burden to the health service. So it's all about getting in there early, getting that DVT diagnosed, recognizing the symptoms of venous hypertension, trying to reduce that venous hypertension, losing weight, exercising, looking and maintaining good skin integrity, keeping the skin moist, trying to reduce the swelling by elevating your limbs, and preventing the venous ulcers. And if venous ulcers do come, then the graduated compression hosiery is an option. We have specialist nurses that deal with that, and that also does work. So prevention. Avoid developing the problem if you can, and that's all I have to say. So thank you very much, and I'll entertain some questions and hopefully come up with some good answers.
Thank you so much, Mike. I think probably we discussed it in exercise after a blood clot session earlier on in the afternoon, the importance of getting moving fairly straight away after you get that anticoagulation into you. How soon are you talking? Like, are you talking within a week? Are you talking within 2 weeks, 3 weeks?
Excellent question.
So I can't hear you.
Just a good question. Can you hear me now?
Yes, a bit, yeah.
Sorry, I'll speak louder. Yeah, it's a really good question. I get asked that question repeatedly. How soon can I get back on my feet? So in the setting of a very large, high-up clot, acutely diagnosed, so in the first 1 or 2 days, we wouldn't recommend excessive mobilization. So, but for a lower down clot, say for a clot below the knee, I wouldn't recommend any period of rest. So for an above knee large clot, maybe for a day or two. But after the first 2 or 3 days, once you're established on anticoagulation, getting moving again is important. So I think as long as you're on an anticoagulant, you're taking your anticoagulation, getting moving in a graded manner within a few days is perfectly acceptable. And certainly after a week, getting up and about, starting to do some exercises, again, very, very important. Swimming, again, I'm a big fan of, and I think, you know, low impact exercise, again, is important in the early days. So I'd really, early on, getting active as soon as possible. Obviously, if you've got a big DVT that's swollen and painful, you're not going to want to walk around, and a lot of those patients are in hospital anyway, and we would sometimes recommend rest for 2 or 3 days. Those patients often are in hospital, have their limb elevated in a little, what we call a gallows sling. But the majority of DVT patients don't get admitted to hospital, are at home, and after a couple of days can return to normal activity. And then after a week or so, starting to exercise.
Okay, I think what I need to explain really to doctors is that it's nothing to do with laziness. It's a complete fear that you're going to die, that clot is going to travel, go straight through your lungs into your heart and just kill you dead. I mean, that is the fear. And can I tell you that I have so many patients that contact me 6 months, 18 months after their DVT incident, where they were put on a DOAC, sent home, might have had just a brief checkup in the clinic a few months later, but had really, number one, have no idea about the medication they're taking, but number two, they're saying, I've put on so much weight, I'm really not feeling well, my leg is absolutely killing me. And I said, what are you doing? Are you walking? Are you getting the blood into that limb? But there's a bit of a lack of information, Mike, do you know what I mean, in general out there?
Listen, again, it's all about, I find patients paralyzed with fear, particularly those that actually have pulmonary embolism as well. And I'm sure you discussed that in previous talks. I mean, PEs, established PEs, people not exercising, getting deconditioned, and actually getting breathlessness from the fact that they're deconditioned. So I think it's really important to realize that it's not dangerous to exercise. It should happen soon after the diagnosis. Now, in terms of DVT, the risk of exercise in a below DVT is zero. There is no, in fact, there's no risk of even pulmonary embolism that we're aware of in the literature. The reason actually we treat lower limb DVTs is primarily to stop the clot extending, growing. So the risk of a PE in a lower limb DVT is zero. So I would recommend getting back to normal activity as pain allows it. For an above knee DVT, no more than a day or two, and I wouldn't recommend complete bed rest either. I would recommend moving around the house. I would recommend going to the toilet as you would normally do. Now, I wouldn't recommend going for a 10K run, but certainly after 2 or 3 days, as long as you're taking your anticoagulation, exercise is just so important. It's important in terms of DVT, of getting the muscle strength back. Remember, it's those muscles that surround the veins, that support the veins, and prevent this terrible syndrome, these slides that I've shown you that you don't want to end up having. And
oh my God, those ulcers are horrific, and I can just feel the pain looking at them.
I mean, they're really what we're trying to avoid, and which is why I've said exercise, exercise, exercise. Don't be afraid to exercise. PE or DVT, the worst thing you can do in the setting of DVT and PE is not to be moving around.
Okay.
Virchow worked this out 100 years ago, worked out why we develop clots. And I'm sure there's someone in the last 2 days has mentioned Dr. Virchow, a genius ahead of his time, who worked out the 3 things that cause clots. One of them was damage to the blood vessel wall. The other was abnormal blood constituency. And the third one was lack of flow, stasis.
Yeah.
Not moving around. The only way to prevent that from happening is to move around, to exercise.
So let's say we have some, and we have a lot of patients out there that are 18 months, 2 years, 2.5 years, whatever, after DVT, didn't get this good news, this information, okay? So they haven't been doing, their leg is swollen, they're having pain all the time, it's affecting their life. Is there hope that they can improve their situation?
Never too late to exercise.
Okay.
Those things may be damaged, and those valves, unfortunately, the valves I referred to, they don't repair themselves. But you have to remember the muscles surrounding those veins act as a muscular valve. So although the little delicate valves are damaged, if you recondition your muscles in your legs, you can actually make up for those damaged valves.
Wow.
You can actually potentially reduce the venous pressure by increasing your muscle strength. And so absolutely there is hope for you. In fact, exercise, you're likely to lose a bit of weight whilst you exercise, as well as then making up for those damaged valves. You've then improved the fact that you've lost a bit of weight, which will reduce your venous pressure, and at the same time, reduce your stroke risk, reduce your heart attack risk, and reduce your cancer risk. So it's never too late. Exercise, reducing your weight, increasing the strength of your muscles to support those damaged veins is the best treatment.
I said earlier at one of the other talks that I found cycling. I'm not a road cycler or anything, but I got an exercise bike. But I found cycling really good because I could get a bit of speed, which kind of helped. Whereas on walking, with the pain, like if you head up a hill or whatever, I was too slow and I wasn't really getting any sort of, a decent workout. I found cycling, I couldn't fall. I was safe on the seat because, when your leg is not getting enough blood flow, it just goes, well, I call it my dolly leg. It feels like it's not really mine. I have pins and needles and my foot goes completely numb. Then it starts to go up my leg and I feel like I'm going to just completely lose power of the leg. But I found cycling really good because some people just aren't water babies.
No, I mean, but again, cycling, think about it. You're taking the effective.
You might.
It's not pounding on the cement that you would have with walking or running. So I'm a cycler as well. I do 280k cycles a week because I can't. I mean, I'm 56 years of age now, and for whatever reason, my left knee has just left me for dead. I can't run. I can't even right. But like yourself, I can cycle, and I do some big cycles to keep my weight down.
Yeah.
And it doesn't hurt my knee because I'm protecting it from gravity. It's the same thing with venous hypertension. Gravity, on top of those little damaged valves, is what really makes it painful. And I think probably, even though I'm not saying I wouldn't recommend walking, Anne-Marie, in people with venous hypertension, but it is painful because you can think about the gravity effects of walking.
Well, you're not inclined to do it if it's hurting you day in, day out. That's the thing.
Swimming, gravity taken away. And if you're not a swimming, I would agree. Next best on my list would be cycling.
Yeah.
There's still a bit of effective gravity, but if you think about it, you're not pounding the pavement. Your legs are moving in a circular motion. Your muscles are contracting all the time. Particularly, you use a lot of calf muscle when you're cycling. And of course, remember, gravity tends to affect the furthest away from your heart. And of course, the furthest away from your heart is your ankle and your calf muscle. And we know it's the ankles is where the venous ulcers occur. So cycling is a fantastic form of exercise.
Brilliant. Okay. That's fantastic, Mike. Thank you so much. That was really informative. And I'm really excited about the fact that we're going to have it on our website, like the recorded webinar on our website, available to everybody to watch probably from Monday. And if anybody'd like to watch it again over the weekend, they just click on the link that they joined the talk on. If they click on it again, they'll be able to watch the recording. Thanks a million. You're so good.
Thank you, Anne-Marie, again for. Am I the last speaker for the day?